Dear colleagues and friends, it's time to start. We are going to make like a big opening ceremony on lunchtime in order to have more audience, let's say. But I have asked and generously Professor Busquet, Jacques, agreed to share the IS EVS history and mission. You know that the International Society of Endovascular Specialists is the leading multidisciplinary endovascular society. And since long time ago, the Balkan Endovascular course, in fact, is the local meeting of International Society of Endovascular Specialists. We have eminent people among us, and we are going to have lecturers from 3 continents. And as always, collaboration and interdisciplinary approach is the main leading topic of the conference. With no more, I will give the floor to Jacques Busquet. Jacques, thank you very much for coming as always, and thank you for supporting us. Thank you.
Ladies and gentlemen, I'm Jacques Busquet from Paris, France. It's a real pleasure and honor to be with you today. I would like to speak of what ISEVS gave to you, to Ivo, and to Sofia. It starts from maybe Donald is in the room, and we are going to speak of ISES. ISES is mainly represented by Dr. Dietrich. Dr. Dietrich was our friend, and he was this type of man, very elegant, that you can see, and we were very happy to be beside him. He lives in Phoenix, Arizona, a very hot state, starting at 4 o'clock in the morning and finishing late with 15 to 20 Ks a day. So this is the institute, or the Arizona Institute, that he built for himself, by himself. He was an innovative surgeon, because he was the first to start the endovascular technique really in the world. I don't speak of the old guys like Crazy Charlie and so on, but he was also somebody having an endovascular vision, and at that time, in the 80s, it was not current, it was not very frequent. And immediately he became an international master. We are, Ivo, Donald and me, the proof of that. Some friends of him were always around him. One celebrity, Thomas Fogarty, recently died, unfortunately. He was editor-in-chief of the journal at the beginning, and Rodney is a very good friend. You know him, he went here, I remember, and he's still very active in Los Angeles. This is something that I like to show. This is my place in France, Bordeaux, very well known for its wine. I heard that you are in competition with us, the Bulgarian wine, so I will test them with you if you want, to see who is the best. And I was interested at that time in endovascular technique. Dr. Dietrich was my master, so we founded the society with this guy, It was not in 2008, it was in 1992. This was a little bit later. This is the last meeting he gave in Biltmore. It was not in the Phoenician, it was in the Biltmore, and we were attending with Donald. This meeting was incredible because gather people from everywhere with the same objective to be the best in their country in endovascular technique. It was the fight against, there was a fight between the old school and the new school. Come in front, please. So since 88, and I went there 27 times, Donald maybe more, and gather all the big names. Here you have some. And we have also some celebrity like Palmas and some of our good friends. And Ted received in San Francisco in 2013 the SVS Innovation Award. It was something important for him because his society fight a little bit against him at a certain time. It was the competition in the world. This was my meeting in Paris, France, and this was the very last meeting of TED in my place. So it's very emotional for me, and maybe for you. Edward Dietrich, we won't forget you. Thank you.
Professor Velchev will start, and we'll invite Professor Matthias to join as a moderator.
Good morning, everyone. We are taking off with the first session, which is devoted to a single question. Should everybody will be allowed and able to block the hole in the vessel? So is it important? And shall we all able to do it, or it should be for some very specialized people? So you know that our circulation is meant to be closed and pressurized. So we have something which is open to the air. Actually, we cannot tolerate this for a long time. The situation should be solved somehow. And usually if you have a bleeding somewhere, independent which territory, usually you have two consequences. You have hypovolemia. At the extreme stage, it goes to the hemorrhagic shock, and otherwise the blood can accumulate inside the body cavities or flow out. And in this situation, we may have melena or tamponade or something related to the hematoma. So what is the link between all these conditions? For example, this is a distal perforation by the wire of the coronary during the acute coronary intervention. This is a bleeding, heavy bleeding for urine, AV malformation. What you saw here is bleeding from sarcoma in the region of the shoulder, which was not well covered by the surgery. So they asked them to do something. Oh, this massive bleeding with rectoregia. So what the common things? All these conditions have a hole in the vessel. So patients are losing blood. And sometimes for the surgeon, which is the classical specialist which is dealing with this problem, it's difficult to achieve hemostasis. So most of the time, there is a rapid solution in the hands of endovascular specialist, but he needs to be trained and prepared because there is a need for a rapid response. Most of the situation cannot be postponed indefinitely until the decision. So what's the problem? Most endovascular specialists, even intervention radiologists, are trained and willing only to cover the complication in their own familial vascular bed, depending on whether they are working with the liver bed or heart or something else. In Bulgaria, at least, in most hospitals, interventional radiology is not even available. I don't know, it's a peculiar situation. And most hospitals in Bulgaria don't have a formal protocol for bleeding management. So what should be the solution? And we will be having a number of speeches about how to deal with this problem. Of course, we need to close the hole as soon as possible in an effective way. And for that, we need a protocol for endovascular response. Of course, the people need to be trained and able to do it because we don't need to sacrifice a vascular bed which is not bleeding. So it should be done in an effective and safe way. Of course, with or without the transfer to the patient to the other institution. And what kind of skills we need? We need a cognitive and technical skills. Of course, the most important thing is to be able to recognize the pattern of bleeding, to be able to deliver a microcatheter to the distal vascular bed, and of course to be able to perform it in an expeditious and quick way. So all these cases were solved by simple closure of the vessel, and you see in a matter of minutes the hole in the vessel is closed, the patient is saved, and it's lucky for the patient that in this situation we were able to do it in a very expeditious way. It seems easy, but it's difficult to learn on emergency cases. So if you wait for the emergency case to learn how to block the vessel, it's maybe not a good idea. So practice is needed, and routine cases, that means that most patients should be involved somehow in tumor or malformation embolization in routine. And of course, where there is a will, there is a way. Okay, and with this, I finish my introductory talk. And maybe we should move to the next speech by Dr. Kamburov.
Oh yes, now it works. So, good morning everybody. Thank you very much for that talk, introduction into the problem of bleeding and its therapy. And now we have the next speaker, and we are curious how he will solve the problem of gastrointestinal bleeding or of bronchial bleeding. We will have both. First now, GI tract bleeding.
Thank you. Good morning, everyone. My name is Dinko Kamburov, and I work with Professor Velchev in the cardiology department at St. Anna in Sofia. So basically, we are cardiologists, but sometimes we need to do interventions outside the heart. And it's a very weird situation in Bulgaria, but just it happens. So yeah, okay. So what is the scope of the problem? There are many GI bleeds, acute GI bleeds, and it's very common. And to put these numbers into perspective, for example, for Sofia, which is around 2 million people, at least, we have around 2,000 to 3,000 acute GI bleedings per year. And of those, most are upper GI bleeds, which means proximal to the ligament of Treitz, and we have lower, which are far few, but the mortality is not that low, between 5 and 10%. And what is the role for the endovascular specialist? Now, usually we go for the endoscopy, which is around 75 to 80% effective, but the last 20 to 25%, we need to go for the second step, and the second step is to do a CT angiography. CT scan, which is very easy to do. It's not that expensive, and it's very fast and is incredible in localizing the bleeding between 0.3 and 0.5 milliliter per minute bleeding, which is very, very, very low bleeding and speed, and the CT scan actually can manage to catch that bleeding. Now, in Bulgaria, sometimes the gastroenterologists go for maybe second, third, fifth endoscopy procedure, and they cannot find the bleeding, but they still refuse to do the CT scan. And I think that we should move to what Western Europe and maybe USA do, which is just do the CT scan. Now, if you cannot find the bleeding, you can do a nuclear study, which means that you trace some erythrocytes with an isotope, and you try to catch the bleeding, because it's easier it's easier to catch it when it's intermittent bleeding. So that means if the CT angio is negative, you can still see on the nuclear scan where the bleeding is, but it's not readily available in almost all hospitals in Bulgaria, to my knowledge. And the third step is to do conventional subtraction angiography, which is very specific and can catch every if you see a bleeding, there's a bleeding, but it's not that sensitive, because it usually needs around 0.5 to 1 milliliter per minute bleeding. Now, what is the good thing about the conventional angiogram? It's that you can actually be therapeutic. What does that mean? We go through the femoral artery, the common femoral artery. We then, depending on the proximal or the lower GI bleed, we select the most common arteries that you can bleed from. For example, if you have upper GI bleeding, then we go for the celiac trunk, the left gastric, which is one of the branches of the celiac trunk, and then we go for the gastroduodenal, which is the common hepatic branch. For the lower, we first go for the superior mesenteric, then for the inferior. What do we look for? We look for blush, extravasation of contrast. That means active bleeding. Sometimes we don't see that, but we can see a mucosal blush, which means there could be a tumor with abnormal vessels, of course, yeah. So prolonged contrast spots, which means inflammation, or if we see very fast artery and vein, usually next to each other, that means that there's malformation, which could be potentially a bleed site. What we can do? We can do embolization through this catheter that we selectively engage the artery. And I searched for a few studies, and almost all studies say that embolization is at least as effective as surgery, but with significantly lower mortality on 30th day, and I think on the 6th month. What is the goal of this embolization? It's to reduce the perfusion pressure and so promote clotting. We need to clot the vessel to stop the bleeding. Now, what is the risk? And what should be very well known by the operator? If you have lower GI bleed, which means distal to the trites ligament, usually the ileum, ileum, and the large bowel, there's very high risk for infarction, which means that we need to be super selective because there's no dual supply of these sites. Now, proximal to the trites, there's rich collateral network and there's lower risk for infarction, but this comes at the price of higher incidence of rebleeding. Now you can see on this image, for example, this is in the ileum. We don't embolize the marginal, the big artery. We need to go in the vasa recte to be very super selective and just embolize a very small part of the ileum. Now, the choice for the right embolic agent is dependent on the operator, and the operator should be very experienced and know every agent and how they act and what do we need to do in the specific situation. The first thing and most important question the operator must answer is, can we sacrifice this part of the organ? This is the most important thing. And then we can go either if you have a large vessel or small vessel. And usually for our lecture, GI bleeding, we need almost certainly permanent occlusion for the large vessel, for example, with coil. We can try to use gel foam slurry sometimes. You can stop the bleeding, but usually the gelatin, which is a porcine gelatin I think we use, usually dissolves in around 3 weeks to maybe 2 months, but it's unpredictable. You cannot rely solely on gelatin to stop the bleeding. And if you have small vessel, then you use, depending on the vessel, but you can use particles which are around 300 microns, which means that you don't block the capillaries, but you block more small arteries. You don't go for the 100 microns. You go for around 300. Usually it's sufficient for small vessel and GI bleeding. Now I will present 2 cases. The first one is for a proximal GI bleeding. This is the Michelson catheter through the common femoral artery, and you can see the celiac trunk. And you, in the right top of your screen, you can see the nasogastric sonde, and there you can see the left gastric artery, and there's somewhat of a maybe blush. And then we use a microcatheter, and we see a few spots with a blush. And in this case, we used microparticles, and we almost completely blocked the left gastric artery with a very good clinical result. The second one is lower GI bleeding. We selectively do angiography of the superior mesenteric artery, and you can see again in the right top corner the marginal artery which supplies the flexura lienalis, part of the colon, and you see there's a bleeding in the colon. We then use, I think first we use gelatin gel foam slurry with somewhat of a result, but there's still some bleeding. So we deployed, so this is the result after the gel foam, and we deployed a coil with almost complete stasis of the bleeding. What are the take-home messages? Now, it's very common to encounter acute GI bleeding, and mostly you can manage it with endoscopy, but you do not need to perform 5 endoscopy to send the patient to CT scan, because it's 21st century, yeah? So have lower threshold for CT scan. It's very, very easy to do CT scan, and just do it. Don't rely on waiting and do 5, 6 endoscopy and just send the patient to surgery, for example. Embolization is very effective. It should be the second option, not last resort. And mostly, as Professor Velchev said, you need to have sufficient knowledge and don't learn on just emergent cases. You need to be prepared before, for example, from tumor embolization, and know your devices and agents that you need to use to embolize and stop the bleeding. And also, of course, it's not weakness to ask for help or second opinion. Thank you.
So thank you very much for that really interesting talk. And you have pointed out that angiography is not only a diagnostic tool, but also a therapeutic tool. That is very important in many questions. If there is somebody who wants to ask something, it's not. Oh, yes.
Just a remark, the problem with this my hospital is that while the patient actively bleeding, usually they are not transferred directly to the angio. So sometimes you see the patient after they bled. And in this situation, if you don't see a bleeding vessel, you don't know what to close. So it's a matter of inter-hospital protocol for very quick transfer or very quick transfer to CT, because if you know where is the vessel, later you can find it.
Yes, our speaker has already pointed that out. Don't be a hero and think you can solve all problems yourself. There are other people in the hospital, and good cooperation is important. Yeah, I say again, thank you very much, and we come to
Thank you.
to the next speaker. Yes, and our next speaker, Dr. Stankov, will talk about acute bleeding of the bronchioles, and so also not a good thing. Yes, I'm curious.
Good morning, colleagues. It's a pleasure for me to present our result of the bronchial artery embolization in our center. Let's start with the problem. This is the definition of the bleeding of the bronchial artery. The massive hemoptosis, 200 to 600 milliliter per 24 hours is the definition for the hemoptosis, massive hemoptosis. Mortality, it's very high, more up to the 50, 60, 18% in treated patient. Primary case of death, it's airway obstruction. 19% origin from the bronchial artery circulation. Etiology, infection, neoplasia, and vascular aneurysm or atrial venous malformation. Pathophysiology, you see the problem is the same, the infection, neoplasia with rupture of the artery and bleeding. One of the crucial in this procedure is the anatomy of the bronchial artery. All of us know this is the very different anatomy. We have 4 tips of the bronchial artery and 30% anatomical variability. And for that, this procedure, it's very difficult to find all artery with rupture and bleeding. And for that, the successful of this procedure, it's not 100%. I don't see any center with 100% successful of the procedure because we have too much anatomic variability and potential origin of the bronchial artery from the subclavian, internal mammary artery, all phrenic arteries. What is most important for the diagnostic strategy and embolization successful of the procedure? CT angiography. We can see the anatomy, very important. The active contrast from the extravasation of the artery, collaterals, and after the date from the CT, we're going with digital subtraction angiography, gold standard, and from the diagnostic, we can go to the procedure and therapy. Indication, massive hemoptosis. It's can be bridged to the surgery, palliative in malignancy, or life-saving procedure. Procedure can be use femoral or radial access, supraselective microcatheterization, avoid particle below 300 micron, and most important to be careful with spinal artery. Here it's embolic materials, different type of embolic materials. PVI, we use in our practice only PVI particles. Microsphere, but it's a high cost, coils only for the proximal embolization, occlusion on the artery. The multidisciplinary management of the patient is very important. Endovascular specialists for the preferred procedure, pulmonologist, thoracic surgeries, and intensive care specialist. This is the meta-analysis of the patient treated for the bronchial artery embolization. The successful is above 19%. Immediate clinical control we have on the 70 to 95%. Recurrence rate 10 to 30%. The reason for this is recanalization, disease progression, missed collaterals, repeat embolization. It can be preferred if it's necessary. Complication, chest pain, dysphagia, transit fever, spinal cord ischemia. This is the one of Meyer, but it's very rare. Complication, bronchial necrosis, esophageal ischemia, stroke. This is our experience for last 5 years. 15 patients treated, all with massive hemorrhagia. 13 of them with neoplasia. In 9 patients, we do a procedure palliative embolization. 4 patients bridging to the surgery. 2 with bronchial artery rupture. Technical, in all patients, CT performed for the planning procedure. We use always femoral artery approach, 5 French. In the 10 patients, we use extra backup coronary guiding catheter for the cannulate the bronchial artery. In the same case, we prefer embolization without microcatheter. In the same case, when it's necessary to prevent the side branch of the bronchial artery, we use supraselective embolization with microcatheter. In 5 patients, we use carotid catheter, Siemens, 5 French, 1 or 2. Technical successes in 13 of 15 patients, 86%. Immediate clinical control of bleeding we have in 12 of patients. Recurrence rate 1 of 13, 7.7%. 1 patient 20 hours after procedure with massive hemoptysis and in-hospital death. 12 patients we discharged 2 days after procedure without complication. This is the first clinical case who I want to present. It's a patient with comorbidity and advanced lung cancer. This is the angio of the left side on the bleeding part of the tumor. We can see, we know on the right side, we have 2 bronchial artery in the most of the people. And this is the embolization of the first artery using the EBU without microcatheter, directly embolization of the artery. And the second artery, we used selective, supraselective cannulation with microcatheter and supraselective embolization only in the part of artery going to the tumor and bleeding. And this is the final result. We see we don't have any more flow on the tumor and bleeding stop. The next patient is a young patient with tumor of the left part of the lung. We can see here, it's very massive tumor with bleeding. This is the angio. We can see the left bronchial artery and bleeding of the distal part of the tumor. We prefer, again, with EVO 5 French, selective embolization of the tumor. But in this patient, we have collateral coming directly from the aorta and going to the tumor embolization, same, and the collateral for the embolization, all part of the tumor. We can see here this collateral from the aorta and embolization. This is the final result in control CT. We don't see anymore the flow on the tumor. And this is the tumor 6 months after procedure. For the conclusion, bronchial artery embolization in the first-line therapy in massive hemorrhagia, it's the necessary multidisciplinary team. In supraselective embolization is the key to save the life of the patient. Thank you.
Thank you very much. Are there any questions from the audience? He was very clear what you presented. No questions.
Great.
Oh, yes, there was a question? No. Yeah, then thank you very much. And we go on in the program. And now in the program, you see there is a live case sponsored showing embolization.
Yes, exactly. In fact, this is the lecture for embolization that I